Assalamu alaikum, Dr. Arshad Mahmood here. In this video, we are going to discuss the BCG vaccine in detail. So, I will try to cover the all aspects of the BCG vaccine, and it is a commonly tested topic in the exam setting, also very important for the clinical practice. So, BCG stands for Bacillus calmette vaccine, and it contains the live attenuated strain of Mycobacteria bovis. So, it is one of the live attenuated vaccines. Indication: it is indicated to prevent the tuberculosis. So it in Pakistan it is routinely administered as per EPA schedule. The route of administration: it is injected intradermally, and the dose: it is 0.05 ml intradermal injection for the infants under 1 year of age, and 0.1 ml intradermal injection for children over the 1 year of age. So it is 0.05 ml for the infants under 1 year and 0.1 ml for children over the 1 year of age. Another important question that is asked: that at what temperature you will store the BCG. So it is 2 to 8 degrees Celsius. Next is the immunization schedule. So it is given as a single dose of vaccine. There is no need of booster of BCG vaccine. So it is preferably given at birth to provide protection in the early years, when the infection can often lead to disease such as miliary tuberculosis and tuberculous meningitis. So importance of this vaccine is to prevent this severe complication that are miliary tuberculosis and tubercular meningitis. Infant may receive vaccine after birth or later, but preferably before exposure to person with active tuberculosis. So once your exposure is done and you have got the organism, there is no use of BCG vaccine. So preferred route of administration is intradermal injection with syringe and needle, because it is the only method of that permits the accurate measurement of individual dose. So important is that its route is intradermal, and BCG is recommended for TST negative, HIV negative infants and children who are at high risk for intimate and prolonged exposure to persistently untreated or ineffectively treated adults. So important thing is that BCG will be given to the HIV negative and TST negative. If HIV positive, no, BCG will not be given, because HIV is an immunocompromised stage and BCG is a live attenuated vaccine that can cause disease in those, or can cause adverse reaction. Similarly, for the person who are TST positive, that means that they are already exposed. So next important concept is that LTBI, that is latent tuberculous bacterial infection resulting from the prior exposure to Mycobacterium tuberculosis, is excluded by a tuberculin skin test before BCG immunization. This is to avoid the risk of an accelerated local reaction that is more common in individuals who have LTBI. In addition, BCG immunization in individuals with LTBI is unnecessary, as it does not provide protection against progression to active disease. So there are two important points why we don't give BCG to the positive TST. One is that if TST is positive, patient is already exposed. If we give vaccine to that patient, it will cause severe reaction. Second is that if patient is TST positive, he is already having the germs, so it will not protect the patient from the disease. So it will be a false vaccine in that scenario. So any child should be going for vaccination. In newborn, we usually do not do HIV testing routinely or TST, but in older children, if we are going to vaccinate them with BCG, so we should have to go for TST before. So for that, important concept is that the time duration in which the BCG provide protection is the 1 to 3 months. So after a period of 1 to 3 months, BCG will provide the protection, as written here, that response is demonstrated by the tuberculin reactivity, which is usually developed within 1 to 3 months. So you can say that after 1 to 3 months, BCG starts its immunity. Now, important of BCG vaccination is that a meta-analysis suggested that 50% effective in preventing pulmonary tuberculosis in adults and children, and the efficacy is 50 to 80% for cases of tuberculous meningitis. So important MCQ here is that 50% for the pulmonary TB and 50 to 80% for the tuberculous meningitis. So best use of BCG vaccine is to prevent life-threatening forms of tuberculosis in infants and young children. So it is important. It is not important for like conditions like BCG lymphadenitis or pulmonary TB. Its efficacy is low, like 50%, but it's high, very high, 80% in cases of severe tuberculosis like miliary tuberculosis or tuberculous meningitis. Not BCG has adverse events that can be occur after injection with the BCG vaccine. So these can be two types. One is localized infection, and other is the systemic infection. The localized infection can be skin abscess, localized lymphadenitis, advanced lymphadenitis, and can be systemic infections like disseminated tuberculosis. So the first event that are skin abscess, localized or regional lymphadenitis, which can occur in healthy children as a part of reaction to vaccine, that is seen in some individuals. While the other part, that is systemic disease, that's disseminated tuberculosis, that is also called BCGosis, is seen in the immunodeficient persons, that can be acquired or congenital, like SCID, that is severe combined immunodeficiency, or HIV, human immunodeficiency virus. So this picture is showing the BCG, local BCG reaction, that is BCG abscess. You can see the abscess here. So next is the BCG lymphadenitis. BCG can cause lymphadenitis. There can be of two types. One is a suppurative and other is non-suppurative. This picture is also showing the BCG adverse effect in the form of non-suppurative lymphadenitis. This picture is showing the adverse effect of BCG vaccine in the form of suppurative lymphadenitis. So how we are going to approach these cases of BCG lymphadenitis? That are two types, suppurative and non-suppurative. So if it is non-suppurative, then conservative management are required. If there are suppurative, then again we can go for the conservative management, but it is recommended to go for needle aspiration, as once the suppuration bursts, there is ulcer formation. Then this ulcer will linger on for the period of months to year. So that will be very painful and cumbersome for the parents. So needle aspiration is recommended. Some people also recommend the isolated isoniazid therapy, and it depends upon the protocol you are following. And for the abscess, again, usually the conservative measures are taken for BCG abscess. Now comes the case of disseminated BCG. This is also called BCGosis. So as per case definition of disseminated BCGosis, the things that should be present are that systemic symptoms should be present, like fever, weight loss, or stunted growth, along with at least two areas of involvement beyond the site of BCG vaccination. So two areas may be involved, that can be in form of lymph node other than the site where the BCG is injected. That can be in the form of visceromegaly. They can be in the form of chest involvement. So and also the BCG vaccine bacteria, that is Mycobacterium bovis, should also be isolated in form of the culture or PCR. That will fill our definition of the BCGosis. So this picture is also showing a case of disseminated BCG disease with involvement of supraclavicular, axillary, and also the patient is also having the signs of malnutrition. So this concept is very poorly understood, that how we are going to treat these cases of disseminated BCGosis. There are different drug regimen that can be used. However, recommended is to start at least 3 drugs and go for the culture sensitivity and then treat according to the culture. Thank you.